Bismillahirrahmanirrahim. Assalamualaikum and good day. Welcome to the lecture on concept and classification of mental illness. I'll be taking you through some terminology we use in mental illness, their definitions and history of classification of mental illness. We'll also go through some concepts and criteria when making a diagnosis in mental illness. Firstly, I'd like you to think of a prominent figure in history, perhaps the pharaoh or a great emperor, perhaps Donald Trump. I'm using Darth Vader as an example here. Did any of us ever think whether he was pure evil or did he have mental health problems? Hopefully, we answered this question by the end of this lecture. Here, I'd like to show you the Vitruvian Man, a portrait by Leonardo da Vinci. It is to remind myself that besides the physical self, there are many other dimensions to a man or woman. This includes the psychological self, the emotional self, the spiritual self, the intellectual self, and I'm sure you know of many other dimensions, including financial, sexual, and religious self. Just so we remember that in psychiatry, we try to be holistic and be mindful of these multiple dimensions in man that may affect his mental health. But first, before we go looking at abnormality, we need to first define what is normal and what is not normal. This is important because those whom we think are abnormal are open to being labeled and stigmatized against. There are several criteria which includes a statistical range with standard deviations of the behavior that you are looking at. Other criteria include social norms. For example, if a naked male was standing in the middle of a shopping mall, would you consider him normal or abnormal? If he was 1 year old, would you consider him to be normal or abnormal? Another criterion would be to put yourself in that person's shoes. Would you be able to do what he does? If a man lies on a bed of nails, is that normal or abnormal? Is it part of culture or is it not part of culture? If a man runs into a house on fire, is it maladaptive behavior? Is it maladaptive behavior if he is a fireman? And if someone becomes sad, that would be deviation from the ideal. If he is sad because a loved one just died, is that normal or abnormal? Therefore, we can see that normality is subject to our own experiences and interpretation of what the patient is going through. Here we go through some terminology. I think you are familiar with the term disease. You often use it when you have a condition with demonstrable pathology, such as coronary heart disease, sexually transmitted disease, and kidney disease. However, in psychiatry, we cannot demonstrate the pathology, except sometimes during postmortem. Therefore, we use the term disorder for when things go out of order in the mind. Another terminology we use is illness. When do we use the term illness? We need to remember every patient's experience with a disease is different and unique to himself. Several patients may have schizophrenia, but each of them go through a different personal experience. One may complain of hearing voices, while another is predominantly paranoid, and another may only have negative symptoms. Therefore, when discussing a patient's case, we talk about his illness rather than the disease he is having. Sickness is another term we use for the social roles we play. We may inform our teacher or employer that we are sick. When we are sick, we are expected to rest or stay in bed. When we are sick, we are expected to take the treatment. When we are sick, we are expected to not do things that will make us sicker. For example, smoking. Some people may take a longer period in the sick role even when they have recovered. if it offers them extended gain in facing their life's problems. So hopefully by now we recognize that mental health includes our emotional, psychological, and social well-being. It affects how we feel, think, and act. Please differentiate between what are feelings, what are thoughts, and what is behavior. The WHO also has given us a definition on mental health. Please be aware that if we are really mentally well, we all have a potential to fulfill and contribute to our communities. Mental health is across the lifetime. Please be aware that we have several subspecialties in mental health. The common ones are child and adolescent psychiatry from 0 to 18 years old, and old age psychiatry above 60 years old. There is also infant mental health, which is to do with how mental illness can affect expecting parents and how they interact and bond with the baby during the first year of life of the baby. So hopefully by now we realize that mental disorder begins after a normal period of growth and development in life, resulting in deterioration of function. Meanwhile, for developmental disorders, deficits are apparent from the beginning of life, and the gap between normal and abnormal life trajectories widens with time. In the meantime, personality develops and consolidates by early adulthood, so much so it is difficult to change personalities and personality disorders once they have formed in early adulthood. Converse to mental health, mental illness affects our thoughts, mood, and behavior. We need to remember that even though our technology at this juncture in time is unable to demonstrate the pathology, we need to remember that mental illnesses are also physical illnesses which manifest largely non-physical symptoms. And that's why the treatment is also physical too, such as medications and electroconvulsive therapy. What is not mental illness? Grief, for example, is not mental illness. We need to remember that political, religious, and sexual differences are not considered mental illness. This is because psychiatrists in history, such as during the Nazi and Stalin period, misused their powers to place political enemies in the asylum and persecute anyone the government did not agree with. Political, religious, and sexual conflict are not considered mental illnesses unless we find other psychopathology as well that signify mental illness, such as depressed mood, self-harm, or hearing voices. Okay, so now we come to the classification systems. We broadly classify psychiatric disorders into psychosis and neurosis. Psychosis is a broad term we use when we mean that the patient has lost touch with reality and has no insight into his condition. One example of psychosis is schizophrenia. Neurosis, on the other hand, means that the patient is very much in touch with reality and has insight into his condition. He knows very much he is ill and he is very miserable about it. Examples are depression and anxiety. There are two classification systems, one of which is currently ICD-10, which WHO and the whole world uses to list every kind of physical and mental illness in the world. It originated from the United Kingdom. DSM-5, on the other hand, originated from the United States and only lists mental disorders. The ICD began in the early 1900s. However, it was only in 1948 for ICD-6 After World War II, veterans returned home with PTSD and depression. That mental illness category was incorporated. Criteria for diagnosis was only added in 1990. Here's a list of broad categories of disorders in ICD-10. The same goes for DSM-5. We see here that the criteria includes symptoms and not the etiological agents, because as I said earlier, we are not always able to ascertain the etiology of mental illness. Other criteria include the duration of illness and socio-occupational functioning. Multi-axial classification means that for every patient, we not only describe the main psychiatric illness in axis 1, but also document in axis 2 whether there is any intellectual disability or personality disorder. In axis 3, we also document whether there is any medical illness in the patient. In axis 4, we document any psychosocial difficulties, such as family problems or homelessness, etc. Here is a list of broad categories of disorders in DSM-5. Broad groups of disorders which we should be familiar with include schizophrenia, depression, bipolar, anxiety, OCD, substance and neurocognitive disorders. Be sure to use screening questions to rule out whether a patient may have any of these symptoms. In terms of hierarchy, organic disorders are placed highest. This is because treatment of the organic disorder may lessen or diminish the psychiatric symptoms, meaning their treatment in the medical or surgical ward takes precedence over any other psychiatric treatment. This is followed by the psychotic disorders, which need to be treated urgently to minimize further brain injury by the condition. Then followed by mood disorders, and lastly, at the bottom of the hierarchy are the anxiety disorders. Traditionally, we have tried to put patients in different categories, like the broad groups of disorders we mentioned earlier. But we realize over time that the patient may have several symptoms that overlap several categories. Hence comes in the axial classification like what we have mentioned earlier. One example of axial classification is in child psychiatry, when we have to consider several dimensions in the child. Different combinations will give us different diagnoses. After a while, after seeing so many patients, making a diagnosis becomes more like pattern recognition. So hopefully we agree by now that these are the criteria for diagnosis. So if we are asked a key feature question, give reasons for diagnosis, please do not just include the symptoms, but also add statements regarding the duration, functioning, and not due to medical condition, and not due to substance use. This is by far the most important slide in this lecture that gives us a guide on making diagnosis. Don't rely on just one symptom. Look at all the symptoms together in the patient. Look longitudinally across the patient's lifetime, not just cross-sectionally. Look, and the number of admissions does not signify the number of episodes that the patient has had, because episodes can start at home, not fully well when discharged, and continue and exacerbate while at home, culminating in another admission. Here are some terminology regarding the cause of illness. We usually say for depression as a recurring illness, because depression can fully remit in between episodes. However, schizophrenia is a relapsing illness because it doesn't usually remit and usually continues as one long illness. Coming on to pattern recognition, you might recognize that this is panic disorder, which you have to confirm the history with the patient. As opposed to generalized anxiety disorder, or GAD, in this patient, can you see the differences in the graphs between this graph and the one before this? And if we signify these signs as mania, psychosis, and depressive episode, you will see that this is a recurrent major depressive episode. And this is major depressive disorder with psychotic features. And this would be persistent depressive disorder, which can last up to 2 years or more. And now, would you like to guess what this is? Yes, it seems that there is a major depressive episode superimposed on a persistent depressive disorder. We call this double depression. This would be a graph for a person with bipolar disorder, filled with depressive and manic episodes and psychotic features occurring during the episodes. You will see that the personality and functioning is relatively preserved compared to this graph of a person with schizophrenia. You can see the marked deterioration in functioning. Why does he have a shorter lifespan? Perhaps you want to look this up and find the reason why. Here we can see the graph for schizoaffective disorder. Hopefully you can see the psychosis is continuous while the mood fluctuates between mania, normal, and depression. Okay? I'm sorry, this is for substance. I'm looking for, yes. This is the graph for schizoaffective disorder. Hopefully you can see that the psychosis is continuous while the mood fluctuates between mania, normal, and depression. And finally, we have the graph for substance-induced psychosis. We can see that the psychosis is related to the substance use. If there is no substance use, there is no psychosis. In conclusion, it is a challenge to diagnose psychiatric disorders because of the absence of physical signs and symptoms. It requires a trained eye and mind to observe the patient's thoughts, feelings, and behavior. However, I hope you appreciate by now that psychiatry is both a science and an art, and that mental health is an absolute essential to our overall health. And finally, can we conclude whether Darth Vader or some American president is mentally ill? Let me remind you that as a professional, we cannot just label anyone to be mentally unwell unless you have personally assessed the patient. And even then, we are bound by patient confidentiality, except in special circumstances, such as in court. Thank you.